Okay, this lecture will cover vascular disease. We'll look first at different clinical manifestations of vascular disease, like the different signs and symptoms, and that would include the different types of bleeding. Review quickly the idea of thrombosis, and then we'll look specifically at diseases of the arteries, like peripheral artery disease and aneurysms, vasculitis, then diseases of the veins, and then edema, and say a bit about stroke. So a couple of important terms to know before we discuss some of the specific vascular diseases would be the different types of bleeding and how we refer to them. So hyperemia just means an active engorgement of tissues with bright red blood. So when you get a sunburn, for example, that's an example of hyperemia. And that's basically due to capillaries, so arterioles vasodilating in those tissues and then capillaries becoming leaky. And sometimes that's augmented by things like histamine, which makes the capillaries more leaky, and then all the plasma leaks out and so forth. So you get some edema with that, but generally the increased blood flow from the vasodilation of the arterioles will create the hyperemia. Congestion means a passive engorgement of tissues with venous blood. So this is more from the venous side and usually due to impaired venous outflow. So you might see that in the legs, for example, with venous stasis, some blood congestion from that. This can happen, for example, in the liver because of right heart failure. So when the right heart fails, all the blood backs up on the right side of the venous tree, or in the venous system in general, right side of the heart. And this will cause congestion in the liver, and that can impact liver function. Hemorrhage is the escape of blood from a blood vessel into a tissue. So that can be from either a large or small vessel, from either arteries, arterioles, or capillaries. And we classify the hemorrhages according to size. So the very smallest hemorrhages would be petechiae. They're about 1 millimeter or less in size. They're usually visible on the skin or the mucous membranes. And this is very commonly associated with low platelet count. Remember, another name for platelets is thrombocytes. So thrombocytopenia would be a low platelet count. Thrombocytosis would be an increased platelet count. But in this case, we have decreased platelets, increased bleeding, and we'll talk about what the causes of that are in the hematology section. But we'll get these little pinpoint bleeds. Those are called petechiae. Slightly larger bleeds would be purpura. They're usually less than 1 centimeter. And again, similar kind of causes. Often this is due to vasculitis or other platelet disorders or clotting disorders. And again, we'll review all the blood disorders in the hematology section. Ecchymoses would be essentially bruises. That's hemorrhages greater than 1 centimeter. Often as the blood leaks out of vessels, it becomes oxidized. It'll turn darker blue, purple. Over time, it'll start breaking down into bilirubin, and that will have a greenish yellow tinge to it. And then hematomas are large collections of blood that are usually the result of trauma, usually not life-threatening except when they happen inside the skull, around the brain, and those can be fatal. So in the neurology section, we talked about intracranial hematomas, like a subdural hematoma. So here's an example of a hematoma in the finger. So just some important words and terms to have in mind as we discuss the different manifestations of vascular disease. Now, in the introduction to cardiac pathology or cardiovascular pathology videos, I discuss the idea of thrombosis. That's basically forming a clot within the bloodstream. And remember, a thrombus really has an ordered structure to it. Unlike a typical blood clot, a thrombus has the so-called lines of Zahn, which include platelets, red cells. There's fibrin in there, then of course layers of white cells, and so forth. So thrombus has a structure. And thrombi can form anytime we have those factors that can precipitate what's called Virchow's triad. So basically when the blood becomes turbulent, or if there's increased blood viscosity, or if there's any damage to the endothelium and exposure of the blood to the basement membrane, all of those factors can increase the risk for thrombosis. And some of the biggest risks that precipitate all that would be our typical atherosclerotic cardiovascular disease risk factors that we reviewed a couple videos ago. Thrombi can form in the arteries, and that would be arterial thrombosis, or in the veins, and that would be venous thrombosis. In arterial thrombosis, they can form on top of an atheroma, and that would be the so-called mural thrombus, and they can actually grow and obstruct the lumen completely. Different things can predispose again, and that would be the factors, the Virchow's triad factors I just mentioned. But for example, atrial fibrillation, where the atrial chambers really just kind of quiver, they don't beat effectively because of an abnormal electrical conduction to the atria. We'll discuss that in the arrhythmia section. That might predispose to arterial thrombosis. And unfortunately those thrombi can form in the atrial chambers, like on the left atrium, pass into the left ventricle, out the aorta, and straight to the brain, and that can predispose towards stroke. The thrombi, if they're fixed, again, that's like the mural thrombus, but they can also break off, and that will be an embolism. And so what I just discussed with the AFib is an example of an embolism. Okay, so that's thrombosis. A term we should know about is an inflammation of an artery. It may or may not be related to thrombosis, but just anytime an artery is inflamed, that's called arteritis. Thrombi will form in arteritis because of the upregulation of all the immune factors there. I'll talk about arteritis in a couple of slides here. So that's arterial thrombosis. Venous thrombi are usually associated with inflammation of the veins, and that's called phlebitis. And so when we have thrombi on top of that, we have thrombophlebitis. And that can occur anywhere in the venous system. The most common example would be a DVT, deep vein thrombosis, that occurs in the lower extremities typically. And those can break off and embolize to the lungs, forming a pulmonary embolus. So I'll have a little slide on that coming up here. Other examples of venous thrombi would be in the portal vein. So you can get a blockage of the portal vein, and that can lead to portal hypertension. In the renal vein, and that can lead to outflow obstruction of the kidneys, and so we start getting kidney damage from that. It can happen in the jugular vein. Budd-Chiari syndrome is a blockage of the hepatic vein, or the inferior vena cava, where the liver drains into the vena cava, and that can cause liver damage here with, basically everything backs up, all the blood backs up into the liver, and we can get hepatomegaly, resulting in ascites and so forth. And then cerebral venous sinus thrombosis. This is basically a clot, a thrombus that forms inside the dural sinuses. Remember, the dural sinuses are what drain all the blood from the brain. So that's forming a thrombus there. And then one important one to know about, I'll just discuss it here, but clinically there's a important type of thrombosis known as cavernous sinus thrombosis. And this is a thrombus that actually forms in the cavernous sinus, which is in the basal dura of the skull. Basically, any infection, inflammation in this triangular region, this is called the danger triangle on the face. So for example, a tooth abscess, nasal infections, anything like that sets up inflammation there can predispose towards a cavernous sinus thrombosis. And this thrombosis will essentially block the venous drainage from this area, and I don't have a picture of it here, but basically that'll compress the pituitary and all the structures around it there, and that can cause severe headache. We call that a thunderclap headache, like a headache out of the blue, but extremely severe. That can result in increased intracranial pressure, resulting in papilledema, which is the characteristic sign in the retina if you do a fundoscopic exam of increased intracranial pressure, seizure, stroke, and then cloudy consciousness. So whenever we have patients that, for example, present with a tooth abscess on the upper jaw, or nasal infections, that sort of thing, we have to be concerned about this possibility. And so we're always on the lookout for any of those signs developing, signs or symptoms developing. Okay, so those are examples of different types of thrombosis, both in the arterial and the venous system. So let's focus on some of the arterial diseases. The first one that's important to know about is peripheral arterial disease, peripheral artery disease, PAD. This is basically atherosclerosis that causes occlusion of the arteries in the lower extremities, so you get decreased blood flow to the lower extremities. It can happen acutely or it can happen chronically. Chronically is probably the most common form, and this is typically associated with what's called claudication. Claudication, basically, you can see that down here in presentation, is cramping in the leg, worse with walking, better with rest. So we get really bad leg cramping and leg fatigue as a person walks, and then when they rest, it gets better. And that's a pretty clear sign that there's not enough arterial flow going into the extremities. And we can do different assessments like check peripheral pulses and so forth to kind of evaluate that. I'll talk about that here in a minute. Acutely, this could be a major artery that becomes blocked by a thrombus, and that causes acute ischemia. And so that would result in rapid onset, intense cramping pain in the limb, like in the calf. The limb becomes pale, cold, and mottled. That's going to be very different from a venous thrombus, which blocks the venous outflow. Then the calf becomes swollen, more purplish. It looks like it's congested with venous blood. So in this case, it's due to a blockage of the arterial supply and oxygen to those tissues. This is basically a surgical emergency because with inadequate perfusion, those tissues can start to die and become gangrenous. So this can sometimes be treated with medications. So there are different antithrombotics and fibrinolytics or surgery. So this is basically a medical emergency. Okay, the chronic would be more associated to, again, the intermittent claudication. And we see this more connected with things like chronic smoking, having an increase of any of those atherosclerotic cardiovascular disease risk factors. This is a type of ASCVD, atherosclerotic cardiovascular disease. So everything I spoke about in the previous videos on that would apply here. The most typical sites of peripheral artery disease will affect the superficial femoral artery. The femoral artery, remember, feeds all the arteries into the legs. The popliteal artery, which is behind the knee, which feeds the lower leg. And then this can also happen in the aorta or the iliac arteries. So anywhere in the bifurcation of where the aorta divides into the iliac arteries here in the lower abdomen. Remember, those are the iliac arteries, and they go into the femoral arteries down here. Or anywhere in the brain and the coronary arteries, of course, and then kidneys. So we can think of coronary artery disease as sort of a variant of this, and we'll talk about that separately in the cardiac disease section. This can happen in the renal arteries, as I've already discussed, causing renal artery stenosis. So those are typical sites of occlusion. Again, it can happen acutely or chronically. If it was acute into the kidneys, for example, or another organ, that can result in failure of that organ, and that's why it's a medical emergency. So the presentation would be the typical with the legs, the intermittent claudication. There'd be usually, if there's pain on rest, it wakes a person up at night. So typically the pain is better after walking, you rest, it gets better. But at night, when circulation slows down, people can start having pain that wakes them up and so forth. And that's going to be a sign of much more advanced and severe disease. If you feel the pulses down in the ankles or the feet, you're going to feel decreased pulses. There'll be muscle atrophy typically. The hair will stop growing adequately on the legs. The toenails become thickened, and the feet feel very cold. And over time, a patient might start developing ulcerations, usually on the toes. It's called ischemic ulceration from lack of adequate oxygenation of blood flow. So that's the typical presentation of PAD in the lower extremities. The assessment would include things biomedically like the ankle to brachial index, and that's measuring the blood pressures at the brachial artery and at the ankle, and then comparing their ratio, the ratio of the systolic blood pressures at either site. So a normal ABI would actually be 0.9 to 1.3. If it's above 1.3, as I discussed a couple slides ago, this indicates the vessels are non-compressible, they're very atherosclerotic, calcified, and that's very severe disease. Claudication, though, typically will be where the ABI is less than 0.7, and if there is pain at rest, again indicating much more severe disease than the ABI usually is under 0.4. So this is a very simple but useful method for assessing peripheral artery disease. Doppler ultrasound is being used increasingly to do this as well, and that's basically where it's a special type of ultrasound that can measure blood flow through the vessels. And so that can quickly see if you're have any blockages in the arteries in the legs. And then angiography, arteriography, this would be basically the gold standard for diagnosis. And when surgeons might have to intervene, they might do that first to kind of see exactly what they're dealing with. The treatment could include just conservative measures for early stage claudication, and that would be basically reducing all the ASCVD risk factors, controlling hypertension, weight, diabetes, etc., hyperlipidemia as well, smoking cessation, gradual exercise. So this is where we do actually want to push them to their limits and a little bit beyond, and that way they start building up more capacity. Checking the feet, and that'll be very important with especially diabetic patients, doing a regular foot exam to assess for any ulcerations, any neuropathy, things like that. A lot of diabetics will lose, due to peripheral neuropathy, sensation in their feet, and so they'll actually have glass or shards or splinters and whatnot, and they won't even feel them. And so it's important that they get regular foot exams for that. Avoiding temperature extremes, and then any sort of antiplatelet agent like aspirin or clopidogrel, as I talked about, the Plavix, might be indicated there. This would be in the herbal traditions like Chinese medicine. Typically this is the classic blood stasis pattern, and so the herbs that address blood stasis are indicated here. So a lot of those herbs include things like turmeric. They would include Chinese salvia, leonoris, lycopis, and so forth, saffron, those kinds of herbs. There's a very interesting Tibetan herbal formula. It's called Padma, I think 25 or 35, but basically it was a Tibetan physician had moved to Europe, and he started seeing patients there, and he devised this herbal formulation, which there's been some research done on it specifically for peripheral artery disease and intermittent claudication, and showing that patients taking this combination of herbs, there's at least 25 different herbs in there. Many of them are blood movers in the Tibetan tradition, but it's very similar to Chinese medicine, that they had tremendous benefit from that. So this is, I think, where adjunctive and integrative care can really make an important addition for patients with peripheral artery disease and really atherosclerotic cardiovascular disease in general. For severe disease, surgery is the option, and angioplasty, where they put a balloon in there, they dilate the blood vessel, and they might put a stent in as well to keep the vessel open. Surgical bypass grafting, and then worst case scenario, if there's very severe ischemia that leads to infarction, there might be gangrene, and that might require amputation. So that is kind of the more advanced cases. All right, so that's a little overview on peripheral artery disease. So again, this is a blockage of arterial flow, usually due to a thrombus. Typically that forms on top of an atheroma, and that results in chronic hypoperfusion in the downstream tissues. In this case, we're kind of focused on the lower extremities. The next arterial disease I want to talk about here would be aneurysms, and these are localized permanent dilations of part of the vascular tree, most common in arteries. A permanent or true aneurysm is a permanent dilation, and that results from a weakness in the muscle wall. So usually it's in the smooth muscle layer, there's a weakness there. And one of the most common predisposing risk factors for that is atherosclerosis, but it can happen because of genetic reasons. There's other different things. For example, we suspect maybe copper deficiency in some people might lead to a weakened wall and so forth. So the wall basically dilates, and this can potentially rupture. Typically an aneurysm involves all three layers of the wall, so the intima, the media, and the adventitia. And again, there's different types. Atherosclerotic is probably the most common. Syphilis, interestingly, chronic syphilis, tertiary syphilis, can weaken arterial walls predisposing towards aneurysm. There can be congenital issues. They're genetic. So, for example, Ehlers-Danlos syndrome or Marfan syndrome, and specifically Marfan's patients are at much higher risk of aneurysm. Ventricular aneurysms, they basically will follow transmural MI. So this would be an aneurysm of the actual wall of the ventricle. And so the myocardial infarction has caused the death of all the myocytes all the way through the wall of the ventricle. And then in days subsequent to that, it ruptures and spills out into the pericardial cavity. And then I mentioned copper deficiency. So these are all different causes and types of aneurysm. Again, causes are genetic or acquired. Aneurysms can be the starting point for on the area that's weakened, that bulges out. There's some turbulent blood flow, and that can actually cause thrombi to form in that area, and those can embolize. So a person's at much higher risk of thrombosis with an aneurysm. Again, it can occur in the arterial or venous system, but arterial is much more common. And as they grow in size, there's an increased risk of rupture, and that would result in uncontrolled bleeding, massive blood loss into internal compartments, and severe hypotension and maybe hypovolemic shock from that. There can be what's called pseudo or false aneurysms, and these are blood-filled spaces that form around a vessel, usually after traumatic rupture or any sort of perforating injury. So it's not a true weakness of the wall, it's usually due to an injury of the wall that causes blood to accumulate, usually between a couple of those different layers, like the intima and the media, and that can cause a pseudoaneurysm. The most common aneurysms would be things like the abdominal aortic aneurysms, AAA. So an abdominal aortic aneurysm is mostly located, it's located in the abdomen, so it's going to be down usually under the diaphragm, usually before the bifurcation into the iliac arteries. And, it looks like a giant balloon that develops here in the aorta, in the descending aorta. Less commonly, it can happen up in the thorax, and so that's another location. So after the aorta comes out of the left ventricle, it goes up and then it curves down. So anywhere here in the thorax, that can be another location. But most commonly, they occur in the abdomen. The incidence increases with age. They're very rare under the age of 50. So typical ages for AAAs would be between 65 and 70. More common in males, but they're more prone to rupture in females. And they can rupture into the aorta is actually in the retroperitoneum, so behind the peritoneal space. And so a rupture there, all the blood would fill into the retroperitoneal space. And the causes would be atherosclerosis, hypertension, smoking, again, syphilis, Marfan's, all the copper deficiency, things like that. The presentation is typically asymptomatic, unfortunately, until they rupture. And they're usually found on just incidental abdominal exam. That's why when we do a full abdominal exam, we actually palpate down to feel the borders of the aorta. And if we feel it over 3 or 4 centimeters, then we suspect there might be an enlargement, and so we might send for imaging to have that investigated. Patient might feel, though, a pulsatile mass in the abdomen. That's kind of a classic finding there. Obviously, with a rupture with AAA, we'd have severe abdominal pain, severe hypotension, and the blood would be filling into the retroperitoneal space. It could be a little leak, and then the symptoms won't be as dramatic. But if it's a severe rupture, usually there's massive blood loss, and most of those cases are fatal because by the time the patient gets medical care, they've bled out. The assessment is abdominal exam. Ultrasound is helpful there. Again, if we suspect a AAA, that's our test of choice, is to get an ultrasound of the abdominal aorta. And then a CT scan gives higher resolution, and that might be helpful before surgery to get better imaging. The treatment of unruptured AAAs really depends on the size. So if they're greater than 5 centimeters or they're symptomatic, that typically is going to be a surgical resection and grafting or stenting. So over 5 centimeters is when intervention is given there. The surgery can be done endovascularly, so through the femoral artery. If it's less than 5 centimeters, usually there's a question mark because there's no clear guidelines. Typically we monitor, we look at, again, reducing any potential risk factors, making sure blood pressure is stabilized, things like that, before any surgical attempts are made. So there's different approaches depending on the size of a AAA. A ruptured AAA is a medical emergency, again, has a very high mortality rate. So that is things to know about a abdominal aortic aneurysm. Now another condition here would be aortic dissection, and that's a tear in the intima that allows blood to fill into the media. So this is not an aneurysm per se, although this can result in a rupture. But basically the blood starts to leak in, so you can see in the diagram to the right here, the blood begins to leak in, cross through the intima, and then starts to accumulate in the media itself. And it basically forces the intima and the media apart, and that space fills with blood. Usually occurs most typically where the aorta exits the heart, so in that ascending aorta where it loops around. So if you look at the diagram over here, site number 1 is the most typical site of aortic dissections. And then number 2, second most common, 3 is in the descending aorta, and then 4 is down here, either in the thoracic cavity or down in the abdomen. The blood can actually back up, so in that space between the intima and the media, can back up into the pericardial cavity, and that causes what's called a hemopericardium. And that basically is where the blood will fill the pericardial space, and that can cause cardiac tamponade, or everything we discussed around the pericardium. And that it can also rupture in the thoracic cavity. So there's two types. Type A, and that's proximal. That's going to occur, for example, at site number 1, whereas type B, the distal type, is limited to the descending aorta. So type A, ascending aorta, B is descending aorta. And we're going to have different treatments for each here. The cause is most typically chronic hypertension. That's in up to 70% of patients. Interestingly, cocaine use predisposes to aortic dissection no matter when a person's used it in their history. So at any point in the past, trauma, connective tissue diseases like Marfan syndrome, Ehlers-Danlos, same we saw with the aortic aneurysms, having a bicuspid aortic valve. So remember in the anatomy, cardiac anatomy section, I talked about how the aortic valve usually has 3 leaves on it. So that's a tricuspid aortic valve. But you can have an anatomical variant where you only have 2 valves. And that's going to predispose you to a number of different things. One is aortic stenosis, would be stiffening of that valve. But another would be potentially increasing the risk for aortic dissection. Coarctation of the aorta, which basically happens from the little duct that connected embryologically the pulmonary veins coming from the lung to the left atrium. They connect directly to the aorta, and that little duct should seal up after birth. But basically, if that remains open or causes a stricture in the aorta, that creates more pressure in the aorta at that point, and that can create increase the risk for aortic dissection. And then the risk is increased in the 3rd trimester of pregnancy. So the presentation is severe tearing, ripping, stabbing chest pain, either in the front or the back of the chest. Diaphoresis, the symptoms pretty much mimic an MI, so this is one of the differentials that are made for patients that are having MI symptoms or chest pain symptoms. Most patients are hypertensive. They can be hypotensive, especially in the late stage. And there is typically a pulse or blood pressure asymmetry between the limbs. So you check the blood pressures on the left and the right side, and they're very different. There could be aortic regurgitation, which you can hear with the stethoscope. And then there can be neurological manifestations from blockage of the carotid artery. So basically poor perfusion to the brain, causing things like hemiplegia and whatnot. So those would be typical presentations of aortic dissection. Assessment would be essentially a chest x-ray, which would show us a widened mediastinum, so greater than 8 millimeters on the anterior to posterior view, an echocardiogram, and more accurately the transesophageal echocardiogram. So that'd be a TEE. A CT scan, MRI, and then aortic angiography might all be used to assess it. So the treatment really would focus on reducing blood pressure and reducing the ejection fraction from the heart, especially acutely. And that would be with IV beta blockers, IV sodium nitroprusside. This is something, remember, one of those emergency agents we can use to dramatically lower blood pressure. And so those would be the immediate medication started. For type A aortic dissections, this is an urgent surgical management. This actually requires open heart surgery. The mortality rate is at least 50% within the first 48 hours of presentation and 90% in the first week. So this needs urgent surgical attention. Type B and the descending aorta usually requires more medical management, and that's going to be decreasing blood pressure with different beta blockers, pain control with like morphine, Dilaudid, and then possibly surgery. So these are not things that are going to present to typical primary care, acupuncture, adjunctive care practices, but definitely it's important to know this is one of the differentials on acute chest pain. And I'll go through that when we look at MIs, what we need to think about when patients present with chest pain, which should be on our list here. And then intracranial aneurysms, we've already talked about these in the neurology block, but basically these typically would be aneurysms at the circle of Willis, involving the basilar, vertebral, posterior communicating arteries, have a very high rupture rate. The muscular wall basically in the arteries there is replaced by fibrous tissue, and that can lead to a subarachnoid hemorrhage or an intracranial hematoma, and that would cause a stroke. So the causes would be either genetic, so a lot of people have these aneurysms, they're silent for all their lives, and it might not cause any problems. Others have the aneurysm and then unfortunately have maybe a minor auto accident at 45 or something, and it causes it to rupture. But we do know that risk factors like high blood pressure, smoking, alcoholism, type 2 diabetes, obesity, and cocaine use all dramatically increase the risk of any aneurysms that might be there to rupture. Two treatment options. One is called surgical clipping, and the other is called endovascular coiling. We put a little coil in there to keep it open. So these are basically neurosurgery techniques to treat that. Okay, so that's a bit on aneurysms and aortic dissection. One other arterial disease I want to discuss here is vasculitis. This is basically a group of disorders that destroy the blood vessels by inflammation. And both arteries and veins are affected. Sometimes it can actually affect the lymph vessels as well, causing lymphangitis, and we consider that actually a type of vasculitis. Primarily, this is caused by overactive immune responses, typically autoimmune or from infection. And they can be classified by the cause, the type of vessel that's affected, or the size of the vessel. So I'm not going to go through this list of vasculitis, the different vasculitis diseases. There's a whole bunch of them. But basically, we can say some of them affect the large vessels. So Takayasu's arteritis, temporal arteritis. This is an important one in the forehead, around the eye and the temple. There's the temporal artery there, and that becomes inflamed. And unfortunately, that has a risk of thrombi can form in there, and they can actually block the blood flow to the eye, and that can cause permanent blindness. So that's one of those medical kind of emergencies we look for. So patients who present with a temporal headache, where you press on that area of the temple, and it's very, very sensitive. Typically, these are older patients. They might have some underlying autoimmune disease, and they're going to be at much higher risk for that. So that's temporal arteritis. Medium vessel disease would be like Berger's disease, Kawasaki disease, polyarteritis nodosa, and then small vessel, I won't go through this, but a common one here is Henoch-Schönlein purpura. Causes the kind of purpura type lesions. And then many other conditions such as rheumatic diseases, rheumatoid arthritis, lupus, cancers like lymphomas, hepatitis C infection, exposure to different chemicals, different drugs like cocaine, amphetamines, and then measles virus can cause vasculitis of intracranial vessels. So all of these would be different types of vasculitis. Again, I'm not going to go through all of these, in detail. It's important just to have a general understanding of what it is and kind of how it presents. Basically, it presents in depending on the type of vasculitis in different ways, but typical things like you'd see a fever, maybe weight loss, purpura on the skin, or petechiae. You could see things like myalgia, myositis, arthralgia, headache, stroke. So it's very generalized this way. But the main thing is we're going to see on the skin some sign usually of petechia, purpura, and so forth developing. There might be in the respiratory system nosebleeds, bloody cough, abdominal pain, blood in the stool, in the kidneys, glomerulonephritis. So it can affect different organs differently. And again, each one would present in its own unique way. The assessment, if you suspect a patient has vasculitis, is to essentially run some typical blood tests. So we'd run a CBC, looking for any anemia, any elevations of white cell counts, especially eosinophils, looking at the inflammatory markers, C-reactive protein or ESR, and then there are specific antibody tests. So anti-neutrophil cytoplasmic antibodies are correlated with a bunch of these. Urinalysis might show hematuria, and then different organ function tests might show issues there. Angiograms could be helpful to diagnose, and then the definitive test would be biopsying a tissue to see, to investigate the blood vessels there and see what kind of inflammatory changes are occurring. The treatment for vasculitis is basically to decrease or suppress the immune response. And so that involves corticosteroids like prednisone, immunosuppressive drugs like cyclophosphamide, and then if there's infection, to do antimicrobials like cephalexin, antibiotic, and then specific organ support is needed. So I'm being very general on this category. Again, this would be a whole lecture in and of itself just to discuss all of these. But just understand that arteries and veins, but more commonly arteries, can undergo inflammation from most typically autoimmune disease or infection. And depending on where it's occurring, in which kind of artery or blood vessel and which organ, you're going to have different manifestations of this. So that's a little bit about vasculitis. Switching over to venous diseases, a very common disease of the veins would be varicose veins. And typically this involves the superficial veins in the legs. And so the veins become enlarged, they become twisted, engorged with venous blood. The occurrence is more common in females than males, so we think there's maybe a hormonal component there. Can occur really in veins nearly anywhere, but most commonly they can happen, we see them in the legs, of course, and that would be the superficial veins of the lower limbs. Can also happen in the anal canal, and that would predispose to hemorrhoids. So we can think of hemorrhoids really as a type of varicose vein. And then in the esophagus, causing esophageal varices, and again that's correlated mostly with things like liver cirrhosis and backup of blood in the portal system. The saphenous vein is also down in the leg, is also very susceptible to varicosities. The causes and risk factors would be due primarily to, we think, to leaky valves. So the wall of the vein becomes more lax. Veins, remember, have very little smooth muscle, but they have some. But if you thin that smooth muscle even further, they become more lax. If they lose some of the elastin and fibrous tissue, they get more stretchy. And the veins actually start to backflow. So instead of being one-way valves, the blood starts to backflow through the vein. We don't know the exact causes of varicose veins. Again, there's many things suspected. We see it run in different families, so we suspected genetic reasons. Hormones in hormone states like pregnancy and menopause, we see an increased risk. From chronic stress, prolonged standing obesity, aging, elevated homocysteine, and then pelvic vein reflux would all be things that have been hypothesized. The presentation, typically, you can see them, but usually we get also sensations of aching and heavy legs, maybe spider veins, that's called telangiectasia, ankle swelling, especially in the evening due to venous stasis and all the fluid is not leaving the lower legs. We can develop what's called stasis dermatitis with redness, dryness, itching. You can see that over here. This is we can create what's called a venous ulcer, basically. And so venous ulcer is very common. We see that clinically. And that's typically due to either the superficial or sometimes the deep veins actually have varicosities, and there's poor venous drainage from the legs. Muscle cramping, poor healing of minor wounds, chronic venous insufficiency, and restless legs would all be part of the presentation. Now the concerns here are the complications. Again, I just mentioned the venous ulcers. Can also have hemorrhage through those ulcers. People will lose a lot of the kind of ooze, often clear fluid, the plasma through those ulcers, but it can be actual bleeding. And then there's an increased risk of thrombophlebitis, and that would basically, thrombi would form in there, and that can predispose a person to increased risk of pulmonary embolism. So varicose veins do have some complications. They're not just cosmetic. They do have complications that have to be considered. Can also have what's called acute fat necrosis due to all the venous stasis. Usually that happens at the ankle. And then some of the very long-standing venous ulcers can actually become cancerous. So there's an increased risk of different skin cancers, squamous cell and whatnot, from long-standing venous ulcers. So the treatment for varicose veins usually can be we can classify it as either being conservative or active. Conservative would be things like elevation, wearing pressure stockings, compression stockings. We do think a lot of flavonoids, diosmin, hesperidine, and whatnot, which are found in a number of different herbs and supplements. We have herbs like horse chestnut and stone root, which is in the mint family, and then witch hazel, things like that, which can be helpful, we think, to really give more support to the venous walls. I've experimented a little in some patients improving their androgens, and that seems to have helped with some cases of hemorrhoids, things like that. So that would be conservative treatment. Surgical would be very radically what's called venous stripping. You'd actually strip the vein out, and there's other veins that kind of take up the slack for that stripped out vein. And then vein ligation, where you tie it off and it basically atrophies. Cryosurgery to freeze the vein. Sclerotherapies, where you inject an agent that makes the vein shrink, or endovenous thermal ablation using radiofrequency or laser. These would all be different methods to address the superficial veins. And in this picture over here, show the stripping of the vein using an instrument called a vein stripper. It's fed through the vein, and then there's an end, and then it's basically pulled out. So you pull out the whole vein. So that's a very radical solution. So hopefully we don't need to get to that point, but that those are all potential treatments for very severe varicose veins. Another venous disease I mentioned before is specifically deep vein thrombosis, and this is basically a formation of thrombus in the large veins of the extremities, or it can happen in the pelvis as well. Again, Virchow's triad would be all the factors that predispose towards thrombus formation. So venous stasis, and that can result from things like bed rest, long plane flights, having incompetent valves like in varicose veins, and then any cardiovascular disease in general. Endothelial trauma, so maybe surgery, injury to lower extremities, and then having a hypercoagulable state like in malignancy, pregnancy, oral contraceptive use. I should put smoking on here as well. These would all be classic risk factors that would predispose one towards increased thrombus formation, especially in this case in the veins. It's going to present with unilateral leg extremity pain and swelling. So typical kind of presentation would be in one calf. You'd see a enlarged calf typically. It would be kind of dark red. It would feel hot to the touch or warm to the touch, warmer than the other calf. It might be painful to touch it as well. There is a physical exam we do called Hohmann's sign, and that's basically where you have the patient dorsiflex their foot, and that increases the tenderness in the calf. That has a very poor sensitivity, so we can't rely on that alone to diagnose a deep vein thrombosis, but that's part of the workup there. The assessment would be primarily through, if you suspect a patient has a DVT, what they need is to get a ultrasound, specifically a Doppler ultrasound, and that's going to be the initial test, and that'll see if there is a clot down there. I had a patient present once for acupuncture for calf pain, and she came in, and I'd never seen her before, and she just wanted some acupuncture treatment to kind of help her calf pain. And I examined her, and it's clearly her calf was enlarged. And questioning her and her history, it turns out she had actually had a DVT years ago. So I immediately sent her for ultrasound, and we started her on anticoagulants, and came out that she had a clot in the deep vein in her leg that was over a foot and a half, about a foot long. And she was at very high risk for that embolizing, causing a PE. So she needed more urgent treatment there. So fortunately we caught that. But that's the kind of thing where a patient with calf pain, be sure we think about things like, is there DVT going on, and do we need to address that? Okay, so that's the Doppler ultrasound. Venography is another, using a contrast agent that can be injected in there. That's a very accurate test. There's different types of tests using alternative tests using electrical currents to look for conduction rates to the leg, and that can be helpful for diagnosis. And then in labs, there is a blood test called D-dimer, which can be ordered. And that has a very high sensitivity but very low specificity, meaning if we suspect it's a DVT and we order D-dimer, it's elevated, that's going to kind of confirm our diagnosis. But D-dimer on itself could result from increased thrombosis anywhere in the body, so not just down in the legs there. So that's going to be part of the assessment. So essentially Doppler ultrasound and D-dimer tests would be our primary initial methods there. The complications would be, of course, pulmonary embolism, where an embolus breaks off, travels to the right side of the heart, right ventricle, and then gets trapped somewhere in the lungs. And I'll talk about PE here in more detail in just a second. It can cause chronic venous insufficiency. It can cause a painful blue swollen leg. And that's called phlegmasia ceruleus dolens. And then that can also increase the risk of edema, varicose veins, varicose ulcers, as we just discussed. So the initial treatment for a DVT would be anticoagulants. Again, not antiplatelets, and a lot of herbs, so-called blood stasis or blood-moving herbs and whatnot, are actually antiplatelet, not anticoagulant. So here you got to go deeper to the anticoagulants. And that's typically initially intravenous heparin, some major anticoagulant. And then after that, subcutaneous injections of low molecular weight heparins. That's going to be the initial treatment. And then long-term, a patient usually is going to be on an anticoagulant called warfarin. Warfarin blocks the sort of clotting cascade by inhibiting vitamin K in that clotting cascade. And so a patient will be usually stabilized on this for maybe up to a half a year. And one of the things that patients who are on warfarin need to get checked regularly is they get a blood test, and they get what's called an INR, an International Normalized Ratio. And this checks their clotting time. So basically, we keep the INR between 2 and 3 on that test, and that would indicate an optimal clotting time. And this is important if you're treating these patients with additional herbal therapy or whatnot. Once they're stabilized on warfarin, adding in any other agents could affect their clotting time because it affects through other mechanisms or platelets and so forth. And so what they're going to need to do is get their INRs checked sometimes 2-3 times a week. Unfortunately, in the US, INRs, the only way you can get them is to go into a lab to have your blood drawn. In Europe, interestingly, they have take-home kits that patients can use, but we don't have that here. And so that's a major disadvantage of warfarin therapy. There are newer agents on the market called novel oral anticoagulants. They're less general than warfarin. They target one specific clotting factor. And the good thing about these is they don't need regular INR testing. And so they have much less risk of fatal bleeding if that INR doesn't stay in the normal range. So they do have adverse effects. We do see increased bleeding episodes with these as well, so they're not without risk, but we don't have to do the INRs as we do with warfarin. There's actually a filter that can be put into the veins in some patients. This is called an intravenous filter, and that basically will prevent any little emboli from traveling from the legs to the lungs. So those would be different approaches using anticoagulation therapy. Thrombolytic therapy for massive clots with any evidence of pulmonary embolism, they go right not to anticoagulants, but the agents that actually can dissolve clots. And that would be things like streptokinase, urokinase, and tissue plasminogen activator. And then in very severe cases, a person can have surgery where that thrombus is resected. And I've actually had a couple patients that needed that. So that is important to always be on the lookout for as a DVT and understand kind of what the assessment and what the treatments are. Now again, one of the major complications of a DVT is a pulmonary embolus. This occurs when a thrombus embolizes via the right ventricle to the pulmonary artery to the lung. And then it blocks blood flow into a portion of the lung, and so that area doesn't get perfused adequately. And so what happens is this will actually result in decreased perfusion of the lung, and that can result in respiratory distress symptoms. But also it will back up pressure in the pulmonary arterial system, and that puts more pressure on the right side of the heart. And over time, if these are happening frequently, it might be asymptomatic to the patient, but the right heart is working much harder to push the blood into the pulmonary artery, and that can result in right heart failure. The right heart starts to hypertrophy, and when the heart muscle begins to hypertrophy, it thickens, it loses that Frank-Starling mechanism, which remember says as the heart is a chamber filled with blood, the more stretched the muscles are, the stronger they can contract. Unfortunately, when the muscle wall thickens, that mechanism breaks down, so as it becomes more and more stretched, as blood goes into it, the resulting contraction of the heart is lessened. And over time, that leads to heart failure. And heart failure that occurs on the right side of the heart due to any pulmonary cause, in this case it can be a pulmonary embolism, chronic PEs, or it can be from chronic lung disease like COPD. This is called cor pulmonale. So cor pulmonale is right heart failure due to any pulmonary disease. In this case, we're talking about pulmonary emboli. Basically, lung areas get ventilation but no perfusion, and again, that can cause a rapid heartbeat, tachypnea, a rapid breathing rate, tachypnea, and a shortness of breath. And the most common sources of these PEs would be deep veins in the legs and the pelvis. So again, we can look for the signs and symptoms of those clinically. Most PEs are what we call clinically silent. They, again, manifest with no noticeable signs or symptoms, but they can occur frequently, and again, that can raise the pulmonary blood pressure, and that can result over time in cor pulmonale. When a PE is diagnosed, if a patient presents with symptoms, the mortality rate is actually 10% in the first 60 minutes. So this is where immediate, kind of like with a stroke, where immediate medical intervention needs to be given. 30% will actually die of recurrent PEs. Most deaths occur within the first few hours of presentation. And treatment with anticoagulants actually drops the mortality rate down to less than 8%, usually, and much lower. So this is where proper anticoagulation and maybe fibrinolytic therapy given early enough are life-saving. So the typical presentation would be shortness of breath, pleuritic chest pain, cough, maybe even hemoptysis, blood in the sputum, low-grade fever, and decreased breath sounds, tachypnea, rales. Remember the difference between rales and rhonchi. Rhonchi are the more bronchial breath sounds. Rales are the crackles that you can hear, and that's usually due to alveoli popping open. Having tachycardia, rapid heart rate with an S4 heart sound. Remember that occurs right before in lub-dub, lub-dub. That's the Tennessee. That happens right before lub. So lub-lub-dub, lub-lub-dub, that sort of thing would be an S4. And then an increased sound on the P2, on S2, the P2 component. And then a massive PE, there might be syncope, shock, and even circulatory collapse. And those are the ones we sometimes hear about. A person went on a 12-hour plane flight, they got off the plane, an hour later they die of a PE because of, a clot had formed, thrombus had formed in their deep veins in the legs, and it broke off and embolized to the lungs, causing a massive PE. The assessment usually in the emergency room is going to be looking at things like the arterial blood gases, looking for any signs of respiratory alkalosis, the D-dimer test, and chest x-ray. So usually the chest x-ray is going to be normal, but that's going to exclude potentially other diagnoses. Doppler ultrasound of the lower extremities to identify any potential deep vein thromboses. And then CT angiography is probably the gold standard test. Actually, pulmonary angiogram is gold standard, but CT angiography is really the most commonly used quick assessment tool in the emergency rooms for a PE. So that would be the typical assessment for PE, and then the treatment again would be similar to what we saw with DVTs, and that would be anticoagulants, thrombolytic therapy, and potential surgical thrombectomy. Okay, so spend a little time on that, but I think that's important because this is a fairly common condition that might be encountered in primary care and acupuncture settings. Next, I want to talk about edema, and that is a shift of water from the vascular space into the interstitial space. It's basically accumulation of interstitial fluids. There's different terms that are important to know related to edema. So anasarca is severe generalized edema. That's edema all over the body, the face, the arms, the legs, and so forth. We have pedal edema, which is localized just to the feet. When it's in the ankles and lower legs, that's no longer pedal edema. Pedal edema is just the feet. Ascites is, we've already discussed this is fluid in the abdominal cavity, in the peritoneal space, typically related to things like liver cirrhosis. Hydropericardium would be fluid in the pericardial cavity, in the pericardial space, and then hydrothorax would be fluid in the pleural space. Clinically, the word effusion is used to describe these different situations, so like pericardial effusion, pleural effusion, and whatnot. So edema and effusion are kind of interchangeable that way. There's two different types of edema, and this is important clinically. There is what's called low protein edema and high protein edema. And the difference clinically is that low protein is pitting. So when you press in on the edema and remove your finger, the indentation remains. Versus the high protein edema is non-pitting. You press in, no indentation remains. And that's a really quick clinical assessment we can make. So if the edema is pitting, if it retains that impression of your finger, this means that the fluid in there is very low in protein, and it's more what we call transidate. So this is basically plasma that's leaked out that doesn't have a lot of protein in it. And there are a couple of causes that are quick to sort of go down the checklist in your mind. The two main groups of those causes would be either from hydrostatic edema, and that would be from an increase of venous pressure. And that basically could be caused by varicose veins. So again, the backflow through the valves would cause increased pressure in the veins, or congestive heart failure. So when the heart fails, all the blood backs up into the venous system. And that can also cause pulmonary edema. But basically, hydrostatic edema would be one cause of pitting or low protein edema. And then the other would be osmotic edema, and that would be caused by either low albumin levels, such as in liver disease or chronic kidney disease, where you spill all the albumin in your urine, or having low levels of plasma sodium. So with pitting edema, I quickly go through these. By far the most common reason is going to be varicose veins. Varicose veins, that's usually benign again, unless we get to the more advanced stages and have those different complications that we just discussed. But we always want to keep in our mind, ask ourselves, is it a problem of the heart? Is it a problem of the more advanced liver disease or kidney disease? And so we always want to keep those three in mind also when we're investigating low protein edema. High protein edema, again, doesn't pit to the finger pressure, and there's two main causes here. One is inflammatory edema, so all the acute inflammation actually, so if you sprain your ankle, for example, and it gets all swollen with edema, that's high protein fluid, and that's from all that inflammatory activity. Remember, your lymphatics are what drain away the high proteins. Your venous system can't drain away the high proteins. So when we see the non-pitting edema, the high protein edema, Means all of it's a problem in the lymphatic system or increased local inflammation, creating all those extra proteins. So that would be inflammatory edema or lymphedema, which is caused by lymphatic obstruction. Again, in this case, the skin would be tense, doesn't pit with finger pressure. The skin tends to has an orange peel appearance, so sort of stretched and gets kind of orangey looking. Often this occurs in the extremities. This can be the result of various things. So metastatic tumors blocking the lymphatic vessels, rarely, very rare in the United States, but you could have filariasis worms. This is what causes elephantiasis. All of that can block the lymphatic vessels. A common reason I've seen in the upper extremities is, for example, after breast cancer surgery, they'll remove a lot of the lymph nodes in the axilla, and those are the lymph nodes that drain the arms. And so you remove that, you block lymph outflow from the arms, and so you get really bad non-pitting edema in the arms and the hands, and that would be due to lymphatic obstruction. So that would be the second cause here, to be lymphedema. So we're always going to think about when we see edema, is this benign? Is it due to varicose veins or something like that? Or is there a more severe reason as to why this is occurring? So the clinical aspects, it's always the result of some underlying disease process. And again, we want to be sure that we're kind of doing a quick differential diagnosis to think that it's not going to be a more severe form that might need a referral out or more specialized care. Okay, so that is edema, very common clinical scenario that we see. Finally, I'll end this presentation on vascular diseases with a discussion of shock. This basically is equivalent to underperfusion of tissues, and this results from either decreased cardiac output or decreased blood volume. Those are the two main causes of shock. And that can occur from a number of different conditions. This can lead to multi-organ failure, and shock can be fatal. So this is not just like psychological shock, this is an actual physiologic phenomena. It's a medical emergency, it needs immediate correction. It is reversible in the early stages, but importantly in the later stages it is not reversible and it's fatal because of the massive physiologic changes that occur. And so this is why addressing shock in early stages is really important. Hypoperfusion is a severe problem, can result in the brain, irreversible brain damage from death of neurons, renal failure, your kidneys die, acute pancreatitis, or cerebral infarction. And so it's important in shock, and again, these are cases that usually present to more urgent or emergency settings. But if you're, hiking in the backcountry, person is injured and whatnot, it's always important to consider, are they going into shock and how do we appropriately address that? So the clinical presentation typically with shock would be tachycardia with decreased blood pressure. And then depending on which organs are malfunctioning, we might see things like lactic acidosis, start to see spilling of proteins in the, a decrease in urination. So in the kidneys we'd see anuria, which is no urination, or oliguria, which is small amounts of urination, and then altered mental status and whatnot due to CNS dysfunction. The initial approach when a patient, for example, is brought to the emergency department would be to do their ABC, so airway, breathing, circulation. That's the first thing. Make sure they have a heart rhythm, they're breathing, etc. And then usually they establish 2 lines with 2 large bore catheters, intravenous, and then they usually do a central line and an arterial line with that. And through this they give different fluids, usually saline or lactated ringers. They'll do blood draws looking at CBC, electrolytes, renal function, coagulation test, an ECG, chest x-ray, and then pulse oximetry. And then if the blood pressure is falling, they'll give vasopressors, and that would be things like IV dopamine, norepinephrine, or phenylephrine. All of these will raise your sympathetic nervous system response and get your blood pressure up. So what are the different types of shock? Well, cardiogenic would result from, most typically, this is a decrease of cardiac output, and most typically that's going to be from an MI. So a person has a heart attack and then they go into cardiogenic shock. But it could be from cardiac tamponade. Remember, that's from, for example, increased accumulation of fluid in the pericardial space or constrictive pericarditis. It could be from a tension pneumothorax, the lungs. Any cardiac arrhythmia, severe arrhythmia, ventricular arrhythmias, whatnot, can result in a loss of cardiac output and you get cardiogenic shock. A massive pulmonary embolus causing right ventricular failure, causing a massive increase of your pulmonary blood pressure, and that causes the right ventricle to fail. Cardiomyopathy, myocarditis, valve defects, and ventricular septal defects, which we've talked about. All of these could contribute to cardiogenic shock. And the treatment here would essentially be to try to identify the cause and then giving vasopressors and so forth. Hypovolemic shock, there's 4 classes, but basically this is due to loss of blood volume. And that could be from hemorrhage, so like trauma or GI bleeding, so a person has a massive bleed. This is one of the main dangers, is we lose enough blood volume that a person starts going into shock. Non-hemorrhagic would be from severe dehydration, severe vomiting, diarrhea, burns, and third spacing, which is movement of fluids from the blood into connective tissue compartments. And so that can result in shock. And this usually, if it's, the hydration is going to need IV hydration and so forth. Septic shock would be from sepsis, and that is usually from bacterial infection. Typically gram-negative bacteria, they release endotoxin, and this is associated with things like pneumonia, kidney infections like pyelonephritis, meningitis, abscesses, infection of the bile ducts, cholangitis, cellulitis, peritonitis. All of those can predispose to septic shock. And here a person usually needs, in addition to the fluid administration and whatnot, vasopressors, IV antibiotics as well. And then finally, there's something called neurogenic shock, which is failure of the sympathetic nervous system to maintain adequate vascular tone. And that can occur with spinal cord injuries, very severe head injuries, or in spinal anesthesia, and so forth. And so basically we get massive peripheral vasodilation and massive loss of perfusion to the tissues. So here IV fluids and vasoconstrictors would be potential things that could be used. So those are the 4 types of shock. When we have a person that's been injured or whatnot, one of the things is to always try to maintain their temperature, so keep them warm. We try to maintain adequate blood flow to the brain in particular, so raise their legs, things like that. So those would all be part of first aid measures to prevent shock. But know the 4 different types of shock, generally what can cause them, and then kind of what the basic approach is to their treatment. All right, so that wraps it up for summary of the major vascular diseases, looking at arteries and veins. In the next video, we'll look at hypertension as another manifestation of vascular disease, and then we'll dive into diseases of the heart muscle itself.